In part one of the discussion on pharmacokinetics, we considered absorption, factors governing absorption generally. In this part three of the discussion on pharmacokinetics, we are going to look at the routes of drug administration. We also look at the factors that govern absorption across these different routes, and we conclude by looking at excretion of drugs. So, what are the routes of drug administration? The routes of drug administration can be classified broadly as enteral and parenteral routes. And the enteral routes include the oral route, the sublingual route, and the rectal route. Whereas when you talk about the parenteral route, you are talking about routes like intramuscular, intravenous, subcutaneous, pulmonary, and others. The oral route is the commonest route of drug administration, and it has the following advantages. Number one, it is the safest, it is the most convenient, it is the most economical. The disadvantages include limited absorption of some drugs through the gastrointestinal tract. Then some drugs can lead to irritation of the mucosa of the gastrointestinal tract, and this can lead to vomiting or can lead to nausea. Then certain drugs are destroyed by digestive enzymes and therefore will not be absorbed. For example, penicillin G. There could also be irregularities in absorption or proportion in the presence of foods or other drugs. Then foods or other drugs can also form complexes with the administered drug or with the index drug, thereby preventing its absorption. Another disadvantage is that this route is not feasible for unconscious patients or for patients that are not cooperative. Factors governing the absorption of drugs administered orally include the rate of dissolution of the drug, the presence of food in the stomach, presence of other drugs in the stomach, the surface area for absorption, and all the other factors as listed here. Sometimes certain drugs are formulated as enteric coated drug. And what this simply means is that acid resistant coating are used in formulating these drugs. And this is done for drugs that can be destroyed by gastric secretion or for drugs that cause gastric irritation. And enteric coating will prevent their dissolution in the stomach so that the dissolution will take place in the small intestine. Another thing that we must note is that oral drugs are sometimes prepared as controlled release or slow release or delayed release preparations. All of them mean the same thing. And the reason why drugs are sometimes prepared as sustained release or controlled release preparation are: number one, to reduce the frequency of dosing of those drugs; number two, to maintain therapeutic effects overnight; number three, to decrease the incidence or intensity of side effects; number four, to prevent disturbing the patient's sleep overnight; number five, to improve compliance in patients. For the sublingual route of drug administration, here absorption is to the superior vena cava. And this route is good for drugs that are subject to extensive first pass hepatic metabolism. A drug like nitroglycerin, which is used in managing angina, is almost completely metabolized when administered via the oral route. Hence, it's usually administered sublingually. Then, for the rectal route, the characteristics of the rectal route of drug administration include that it is good for unconscious patients, It's also good for children and also good for patients who are vomiting. For example, children who have children who have febrile convulsion. Yes, febrile convulsion. Sometimes rectal diazepam is administered to them prophylactically, in which case the diazepam is administered via the rectal route once you notice that they are developing fever. And with this, the likelihood of them developing convulsion is markedly reduced. Another characteristic of the rectal route of drug administration is that they are subject to less hepatic first pass metabolism. However, drugs that are administered through this route are subject to irregular and incomplete absorption, and the drugs can also cause rectal mucosa irritation. For the parenteral routes, you have the transdermal, the intravenous, intramuscular, subcutaneous, intraarterial, intrathecal, pulmonary, and topical. Absorption from the intramuscular and subcutaneous site is by simple diffusion along the concentration gradient from drug depot to plasma. For the intravenous route, this route has the following advantages. Number one, there's no need for absorption since the drug is being deposited directly into the blood. Then the bioavailability is 100% since there is no absorption, since it's not passing through the portal circulation, there is no hepatic first pass hepatic metabolism, thereby bioavailability is 100%. Then another important advantage of the IV route is that drug delivery is controlled and achieved with an accuracy which is not possible with any other route. This is important, for example, in anesthesiology and certain other situations also. Then drugs that can irritate the GIT or drugs that are corrosive to the GIT can be administered via the intravenous route. Of course, it has its own disadvantages also, and these include risk of dangerous reactions, risk of infection, then special equipment may be needed, then there's usually a need for an assistant. For the intramuscular route of drug administration, simply, the drug is administered into a muscle, could be the gluteal muscle, could be into the vastus lateralis, could be into the deltoid muscle. Absorption via the intramuscular route is very good, and it may be accelerated by local heating, by massage of the area, or by exercise. Then hot bath also increases absorption of drugs that are administered intramuscularly. We should also know that absorption of an aqueous solution into the deltoid or vastus lateralis is faster than in the gluteus maximus because of more subcutaneous fat in the area of the gluteus maximus. To delay or prolong the effect of drugs that are administered intramuscularly, the drug can be prepared as an oily solution, or it can be suspended in other repository vehicles. For example, steroid hormones like testosterone can be prepared as esters like testosterone enanthate and other esters of testosterone. Same thing is applicable to estrogen and other steroid hormones, progesterone, and others. Then the pulmonary route. Pulmonary route is suitable for gaseous and volatile drugs. And these drugs that are administered through this route are absorbed through the pulmonary epithelium and also the mucous membrane of the respiratory tract. Advantages include rapid effects, avoidance of hepatic first pass metabolism, then the drug that is so administered is concentrated at the desired site of action in cases of pulmonary diseases, for example, bronchial asthma. Therefore, the systemic effects of drugs administered through these routes are minimized. Then topical application is another route, and when we talk about topical application, we are talking about application through mucous membranes of the conjunctiva, nasopharynx, oropharynx, vagina, colon, urethra, urinary bladder. So drugs can be administered through these routes to produce local effects. However, some of the drugs administered through these routes can also be absorbed and cause systemic effects. For example, eye drops may result in systemic absorption through by passage through the nasolacrimal canal. The transdermal route, absorption through the transdermal route is dependent on the surface area over which the drug is applied and also on the lipid solubility of the drug. Absorption through the transdermal route can be increased by suspending the drug in an oily vehicle and rubbing the resulting preparation into the skin. Then use of occlusive dressing, whereby the drug is placed on the skin and then covered with a nylon. So the application of the nylon will lead to moistening of the area, will lead to hydration of the area, and then the hydration will enhance the absorption of the drug that is so administered. Bioavailability is something we must quickly look at here, though we are going to look at it more closely in a different lecture. So what is bioavailability? This is the fraction of unchanged drug that reaches the systemic circulation following administration by any route, and it is affected by the extent of absorption of that drug, by first pass metabolism, by rate of absorption. We are going to discuss it in greater detail later. Quickly then, let's look at excretion. And what is excretion? Excretion is a process whereby drugs and metabolites are irreversibly transferred from the internal to the external environment, or the passing out of systemically absorbed drug. Drugs can be excreted either as the parent drug or as metabolites. And the routes through which drugs are excreted are the kidneys, through bile and feces, through lungs, through sweat, through saliva, through tears, through breast milk. The most important, by far the most important among all these routes is the renal route. And the kidney is the primary organ for removal of most drugs, especially water-soluble drugs. Then the lungs also is important for volatile drugs. Now, in considering excretion via the kidneys, we must remember that the amount of drug or its metabolites that are present in urine is the sum total of the glomerular filtration, tubular reabsorption, and tubular secretion, which are the three factors that determine the urinary excretion of a drug. Then, we should also note that the non-ionized acids and bases are reabsorbed in the proximal tubule of the kidneys. So glomerular filtration, the amount of drug entering the tubular lumen depends on the glomerular filtration rate and the protein binding of the drug. Remember that the glomerular capillary wall is freely permeable to water but restricts the passage of compounds with large molecular weights. And filtration of large molecules is influenced by their molecular weight, charge, and the shape. Also note that unbound drugs of low molecular weight are freely filtered. Then, we should also note that renal function at the extreme of ages are low or are not as good as they are in young adults. And glomerular filtration rate declines progressively after the age of 50 years. And in elderly people, there's some degree of renal impairment, which is important for excretion of a lot of drugs. A lot of drugs are not filtered, but are secreted into the tubular lumen at the proximal tubule. And this secretion is against the concentration gradient, and it is carrier mediated. The secretion of such drugs is mediated by carriers such as the ABC transporters, the multidrug resistant associated protein type 2, the P glycoprotein, and secretion is important in the excretion of charged anions and cations and in the excretion of protein-bound drugs. Then for tubular reabsorption, certain filtered substances are reabsorbed in the proximal and distal tubules. And we should know that endogenous substances such as ions, glucose, and amino acids are almost completely reabsorbed. Then 99% of lipid-soluble drugs filtered at the glomerulus are reabsorbed, but non-lipid-soluble drugs and highly ionized drugs are not reabsorbed. So changes in urinary pH affect tubular reabsorption of drugs that are partially ionized. Thus, weak bases ionize more and are less absorbed in acidic urine, whereas weak acids ionize more and are less reabsorbed in alkaline urine. This is important in cases of poisoning. Alkalinizing the tubular urine will lead to ionization of weak acids and hence their increased excretion. Then when the tubular urine is made more acidic, the fraction of ionized drugs is reduced and excretion is reduced. So alkalinization and acidification of urine has the opposite effect on the excretion of weak bases. Lastly, for biliary and fecal excretion, we note that drugs and metabolites are secreted into bile by the hepatocytes, and the same transporters that we mentioned earlier, the P glycoprotein and then the multidrug resistant associated protein type 2 that are present in the kidneys are also present in the hepatocytes, and they are responsible for secretion of drugs into bile. So the drugs that are secreted into bile are excreted into the gastrointestinal tract. And then from the gastrointestinal tract, such drugs might be excreted through the feces, or some of them will undergo what is known as enterohepatic recycling, whereby they are acted on by intestinal microflora and reabsorbed. And this can prolong the effects of such drugs that are subject to enterohepatic recycling. So to prevent enterorecycling of drugs, resins or activated charcoal can be administered orally. So this will bile the drugs that are excreted in bile and prevent their reabsorption. Then drugs are also excreted into saliva, into tears, into sweat. Drugs that are excreted into saliva are swallowed and then excreted in feces. However, sometimes the concentration of drugs in saliva is at equilibrium with the concentration of drug in plasma. And in situations where it is impractical or difficult to obtain blood sample for analysis of drug concentration, the saliva might serve. Then for breast milk is important because the baby may be exposed to the effects of drugs that are administered to the mother. Then for other routes of drug excretion, the hair and the skin are only important for forensic medicine or for forensic purposes. The last slide is showing us some of the drugs that undergo enterohepatic circulation. The list is not exhaustive. There's still a lot of other drugs that are not listed here. So I will encourage you to check for other drugs that undergo enterohepatic circulation. Thank you.